Should the dosage gap between two doses of Covishield actually be 12 to 16 weeks, or should it revert back to the 6 to 8 weeks that was recommended earlier? This question has been doing the rounds for a while now and came to the surface once again when a newswire reported that the group that decides these things and recommends this to the government, the NTAGI, 3 members of that group claim that they never gave their approval or their nod to increase the gap between 2 doses of Covishield to 12 to 16 weeks. The government has quickly responded by firefighting, saying that this decision was taken on a scientific basis and very much with the scientists on board. So what is the full story? What is the true story? And why has this confusion come to the fore? To speak on this, I'm joined today by Dr. N.K Arora. He's the chairman of the COVID-19 Working Group for NTAGI. That's the National Technical Advisory Group on Immunization, which is a cohort of scientific minds that advises the government on how to go about COVID-19 vaccination. Dr. Arora, thank you so much for speaking with us on the India development debate. Let me ask very clearly first up, did the committee in unequivocal terms recommend increasing the dosage gap between 2 doses of Covishield to 12 to 16 weeks? Were you asked for this recommendation and did you concur?
So thank you very much, Tamanna, for inviting me. I would like to give a brief synopsis of the process, the way decisions are made. So the first is COVID-19 working group, which looks at the issue in depth, does the literature search, and responds to a policy question which has been forwarded to it from NTAGI. And thereafter, this decision is taken over to the STSC, which is the scientific group arm of the NTAGI, where this decision is relooked, discussed threadbare, and finally sent up for ratification by the full NTAGI. And we discussed this issue of increasing the dose interval, used the data which was available from the Oxford trials, number one. Number two, we used this data which is available from the field after they had used 12-week interval for AstraZeneca vaccine in UK. The third thing is that Public Health England had published their experience in last week of April, or 3rd week of April, that the 12-week interval was giving 65 to 88% vaccine efficacy. Simultaneously, we were fortunate that the innovator of the vaccine, Andrew Pollard, also was invited as a special guest for this meeting, and he showed us the basic data, the mechanistic data, and also the data from the trials, and clearly indicated that anything at least 12-week interval would be a good idea for our country based on the various other factors. This decision, the way our committee functions, that if there is any dissent, in the minutes the dissent is documented. And minutes are circulated before we move on to the next level. There was no dissent at this time. Then we moved on to the next level, which is the STSC. Again, this was discussion, and in the minutes it was written that at least 12-week interval will be given. And here I must say that the initial AstraZeneca data is showing, and the trial data is showing, that at 4-week interval, the vaccine efficacy was 57%. At 8 weeks, it was 60%. At 12 weeks, it was 63%. And more than 12 weeks, it was 12 to 44 weeks, it was around 75% vaccine efficacy. So adeno-vectored vaccines behave differently as compared to many other vaccines. The context is important. the geography is important, and therefore it behaves differently. But the data was showing, then the field data from public health, and this data which we looked at and reviewed was the same data which UK had collected during the surge of alpha variant in their country. Okay. January, February, March, that was the data. So clearly during that period, this vaccine was working. And 12 weeks, and that is why we thought that it would be a good idea. But we said that we have to have our own data, that a decision was made that a vaccine tracking platform will be established. And while ICMR had already started working from April onwards on this vaccine tracking platform. In the NTAGI meeting, there was discussion, and
Doctor,
the minutes were circulated. I'm coming to the dissent part of it, that there is discussion, various aspects are discussed. One of the important thing was that the minuting at the STSC was very clearly at least 12 weeks interval is to be there. Now, from a programmatic purpose, you don't expect anybody to land up on 12 weeks only. So 12 to 16 week period was given in the final NTAGI minutes. And the reason is that programmatically you need to give a slot. And then we looked at the international the schedules also. Canada is also giving at 12 to 16 weeks. Our next door neighbor, Sri Lanka, is also using 12 to 16. And that is how this magic figure of 12 to 16 came, that we also went in for 12 to 16 weeks, but closely monitoring what is happening. And thereafter, we have been monitoring. We are looking at the field data, and there are two studies which have been published in last 10 days. One study from PGI Chandigarh, which was basically during the period of alpha variant, which was causing the surge in Punjab and Chandigarh and adjoining areas. And it showed...
if I may come in. Yes, Dr. Arora. Yes, Dr. Arora. If I may come in, I know you're giving me the sequence of events, but you know, yes. Yeah, so I want to specifically ask about this report because it quotes 3 committee members. It quotes MD Gupte, Matthew Verghese and JP Mulial, who seem to be saying that there was no specific recommendation of 12 to 16 weeks, that this was the government's idea and it could be correct, it could not be correct. So has this come from this group of scientists that let's increase it to 12 to 16 weeks, or was this an idea floated by the Health Ministry or the Government of India, which then you've put your stamp on?
So the NTAGI minutes, the STSC minutes very clearly say at least 12 weeks, and these minutes were circulated. At least 12 weeks means 12 weeks to some level, it has to be taken in. And programmatically, it was considered 4-week interval is required. So this decision, program people are also part of NTAGI. And that is why in NTAGI, 12 to 16 was decided. From STSC, the recommendation went that at least 12 weeks interval will be kept. And there is a provision if a member has any dissent or different views, they should put it, and it is put in writing. And there have been incidences even before when the dissent has been documented into the minutes. And we did not have any dissent comment at that time in the NTAGI minutes.
Okay, let me then come to the question of whether there is a review under process right now. You've been quoted as saying that the committee is mulling reverting to the 4 or 8 week interval. Is that something which is being thought about right now, especially in the context of the Delta variant, which may have more harm and give less, even one dose may give less protection against it?
So there are 3 things I would like to share with you. 1, 75% of the vaccinees today in India have received only single dose. Out of 26 crores, only about 18 crores have received 1 dose, and 4 or 5 crores have received 2 doses. Number 2, so that's a ground reality. And second issue is that a week ago, there was a publication from PGI Chandigarh which clearly said it was in health providers and several thousand people were there, which showed that if you have received single dose or if you have received 2 doses of Covishield, in the short run, vaccine effectiveness is 75%. This is in public domain, published data. 2 days ago, data from Vellore has come, and that was during the outbreak of alpha variant. Now, the data from Vellore is during the peak of Delta variant outbreak, April, May, and which shows that single dose vaccine efficacy is 61%, 2 doses is 65%, and there is no much difference. The key is here that if somebody receives even a single dose, in the short run, I would underline in the short run, the person is protected from severe disease and hospitalization and death. That's a very important component. And that is what we have the evidence right from our own country. And there is nothing written or cast in stone. We are continuously monitoring the situation. Vaccine tracking platform is also will be coming up and regularly sharing the data. And as and when required, there will be a review. Whatever is required in the best interest of providing immunity to our people, that will be done. But immediately we continue as we are at the moment and continue to immunize our people with the same vaccine interval.
Okay, so two questions. One is, when you say in the short run, what does that mean? How do you define that short run, and after what point does it become imperative to have a second dose to be covered?
Yes. So our vaccine platform will give us that when it becomes difficult, that the advantage of that short run. Short run may be 2 months, 3 months, 4 months, 5 months. We are not aware at the moment. But whatever data is there, because January we started, today is the same date of June, it means 5 months have passed. And therefore, this is short run in that sense. And it is providing the, because all the people who received even in January or in February or anywhere till now, they are all part of both these studies. And therefore, I'm saying in the short run. But it is, the situation is being monitored, and we will have regular bulletins also from vaccine tracking platform, so that it is transparently shared with everybody and decisions will be based on scientific.
So as of now, I just want to understand, Dr. Arora, as of now, as of today, there is no consideration of shortening this gap in view of the Delta variant. It's not under consideration at all?
No, at the moment we are closely watching the situation. Immediately, there is no plan for changing the interval between 2 doses. And the other context is that
is it being considered?
The wave is also on the wane.
Sure, sir, but is it being considered, looking at the fact that the UK that you cited as a model in the earlier decision has also reduced the gap? First, they reduced it for those above 50 and now for those above 40 as well. They are seeing an upsurge after the Delta variant has spread there. So in light of that, is it going to be considered, or is it being looked at as an option? You said very clearly that as of now, there's no plan to change the gap, but is it being considered?
So that's what I'm trying to say. We are closely monitoring the situation in our own country. There are more studies going on this issue. We are regularly monitoring. I am privy to at least 2 more or 3 more studies, and we are looking at that, and there doesn't seem to be any issue of major concern. And from 400,000, we have come to 40,000 cases already on this epidemic on the surge. And but notwithstanding the decreasing number, we are still very closely watching the interval. And now onwards, I think we will be fortunate.
While I have you here, Dr. Arora, yes.
We'll be using more often our own data.
While I have you here, Dr. Arora, I must ask you about Covaxin. I must ask you about Covaxin phase 3 trials, when they will be out and why are they not out yet? The biggest, most immediate concern that people are having, those who have been inoculated with Covaxin, is that they're finding it difficult to travel abroad because many countries don't recognize it as a vaccination. The WHO doesn't recognize it. What are your thoughts on this and how can we rectify the situation?
So, first of all, this question should be asked to Bharat Biotech. They should be the right people. But as far as I am aware, and that over next couple of weeks, this issue, they have been analyzing the data, and we have been given the impression that in next few weeks they will be submitting the data both to WHO as well as submitting it for publication. So it's a matter of because from the COVAX facility, I am part of the COVAX global COVAX facility also. There is a pressure that as many new vaccines are registered with emergency use listing of WHO, better it is for the world. So I hope that this will be done soon, and our countrymen will not have the difficulty you are mentioning.
Okay, I'm also asking you, sir, because as the chairman of the committee on NTAGI, you would know about safety and efficacy. So you are convinced that it is completely safe, even though the phase 3 data is not out?
No, we are, all of us are privy to the complete phase 3 data. We are completely aware, and we have done the vaccine trial. We have looked at the safety data also for this, both from the trial as well as from the program, and we don't find any safety signals so far.
All right. Thank you so much, Dr. Arora, for joining us today and clearing up the air, especially on the gap between doses of Covishield. Dr. Arora saying that there is no requirement, there is no plan to change that gap or reduce it as of now, but it is a situation which is being watched very carefully. Thank you so much for speaking with us.
Thank you.